seem to be having these issues in the pelvic floor. And more of my gynecologic patients seem to have these symptoms when they come in and want to talk about them. So I started looking at these issues and realizing how easy it is to actually look at the pelvic floor and determine some of the more straightforward diagnoses. Now, the pelvic floor has borders. It includes the symphysis pubis, the inferior pubic rami, and the coccyx. And that basically is what borders it. The muscles and the connective tissues have to maintain tone, otherwise everything is going to fall out. So we stand and gravity starts to pull, and we need to be able to urinate, defecate, and have childbirth, and yet when we don't want to do these things, that everything remains in place. So it's actually a very dynamic and difficult area of the body. And in fact, a lot of women, 24 to 38% of women, and certainly as you get older, more and more suffer from pelvic floor symptoms. The indications for the scans are listed here. Basically recurrent UTIs, urgency, frequency, incontinence, pain. There are a lot of people who have pain with urinating, avoiding dysfunction, not being able to empty completely, prolapsing in the vagina. All sorts of things can prolapse, the bladder, the rectum. There can be vaginal pain, dyspareunia, pain with intercourse, fecal issues, incontinence, and certainly masses can occur down there. We'll cover all of those things, including talking a little bit about the bladder, which is sort of what I call the forgotten organ that we sort of bypass when we do a pelvic ultrasound. So here is an image that I've taken off the web and turned upside down, basically, because that's the way we look at the pelvic floor. We put our probe. You can use a transvaginal probe or you can use an abdominal probe, and you cover it the same way that you would a transvaginal probe, and you put it right on the perineum. And so as we put it on the perineum, we can see the urethra, the vagina, and the rectum. And so this is what we see by ultrasound. There's the urethra. So here the patient is upside down, head down, feet up. This is the urethra, and it goes into the bladder. Here is the vagina, and the rectum is over here. You can see some of the shadowing of the rectal verge right here. So when we look at the floor of the pelvis, it's really using 3D. 3D is extremely important to do this examination. It's only after 3D that I realized how easily ultrasound can lend itself to doing this. Because with 3D, as I'll show you in a moment, you can actually look at the floor of the pelvis from below en face, if you will. And these are the components that we look at. The major muscle here that everybody really talks about, that's a major muscle that holds everything in, is the levator ani. The levator ani is made up of 3 different parts, the puborectalis, pubococcygeus, and iliococcygeus. There are many other muscles here, but those are the ones that get talked about the most and get injured the most in childbirth. So here we have the urethra, the vagina, and the rectum. And so let's go on and see how that looks by ultrasound. So here we are about to do a 3D. This is my acquisition view right here, and I've got the vaginal probe. I use a vaginal probe to do it. It has high frequency, and it's easy to sanitize. You can look down the urethra, down the vagina, and down the rectum, and this is a rectal verge right here where it bends. And if you put your box that you're going to do your 3D with right in the middle here, and you press your button, automatically you will get this basically C-plane or Z-plane, which is the floor of the pelvis. And here all I've done is done a sort of a thick slice technique and turned it right side up. And now you can see basically what we saw before on the diagram. You can see the urethra, the vagina. The vagina has a sort of a smiley face because it's held up on each side by the levator ani. And then you have the rectum. You can actually even see the mucosa of the rectum and the internal-external sphincters. So the pelvic inlet, what we call the pelvic inlet, is right here. It's actually a trapezoid type of or probably ellipse, if you will, type of configuration that contains the urethra, the vagina, and the rectum. And then you can see that the internal sphincter here is echo-poor, and the external sphincter is echogenic. And it's bounded by the levator ani muscles on both sides. And here is a different case where you can see even more detail of the rectum and the vagina. And if you get the angle right, you can see these little tiny glands that are on either side of the urethra. These are called scheme glands, and they're the counterpart to the prostate in males. And they're right on either side of the urethra. And again, you can see the smiley face vagina here and the rectum behind it. And this very thin area here is the rectovaginal septum, which is so important. There can be fistulas there, there can be endometriosis there, be all sorts of things. So one of the biggest problems that occurs, particularly after multiple childbirth, is bladder descent. And there have been different ways of treating it. One way is to put a sling or a mesh across the back of the urethra. So here we are again on our acquisition mode. And here I've made the area that I'm going to do 3D very thin because I just wanted to involve this one little part right here which transects the mesh, which is right there. So when you take your 3D here, what you're rendering is just the part in there, in that rectangle. And so you see the mesh right here, and here is our sort of enhanced view where you can actually see the mesh is slung around. And many people that I see with meshes are actually pretty happy with them, seem to be quite pleased, except of course when they don't work, which I'll show you some examples of that. So here is what happens when people need to have this fixed. Here is the urethra, there's the vagina. Now I'm going to ask this patient to Valsalva, and she's going to push, and what happens here? Well, the bladder descended into the vagina, so it came into the vagina. It's only about 1 centimeter away from the probe here. And what happened to the urethra is it went from being vertical to being horizontal. And I'll tell you, very hard to pee with a horizontal urethra. It just doesn't come out. And I know that there's a lot of people who make measurements, who make angle measurements, descent measurements, and so forth. As many of you know, I'm sort of not a measuring type, so I'm looking at it here and I say, clearly this is abnormal. This is a cystocele that comes down with Valsalva. So when you have a cystocele, a lot of times you can't void completely, and I'll show you why. So here is a cystocele without even Valsalvaing. This bladder is starting to migrate into the place where the vagina is supposed to be. And when she Valsalvas, look at what happens. The whole thing just rotates, and the bladder basically descends down to the probe. So it actually comes right almost out, and so clearly this part of the bladder can't possibly be empty. So let's look at this in real time. So here's somebody who's already got a bladder prolapse. You can see the urethra is bent to a certain extent. This patient can't void completely, has urinary tract infections because she can't void. And she's got this thing that's already sitting in her vagina. So let's see what happens when she Valsalvas. So she's going to Valsalva. and that the whole thing goes down, and you can see that things really clamp shut here so that she can't possibly empty the rest of her bladder. And so she will always have that amount in her bladder even after she voids. And not only that, but she'll have a bulge that will be attempting to come out her vagina. So this is a 3D of such a patient showing that at the level where the bladder should be well away, well up in this area here, it has descended to within about a centimeter from the vaginal probe on the introitus. And in this 3D view, you can see I've put the dot on the descended bladder, and you can see it in all three views, so that if you try to do a pelvic floor where you would have seen the urethra, the vagina, and the rectum, what you see is the bladder. So this is exactly a similar case where you've got the bladder has already descended, so it's there. Sometimes if you look at a patient that has a prolapsed bladder, you can almost see it come out of the vagina, and you sometimes have to push it back in to examine the patient, as we did in this particular case. Here the bladder is just about all the way out, and you can see that we can't even see the urethra. It's probably bent or it's actually probably perpendicular right here. I mean horizontal right here, and so that this part of the bladder cannot be emptied. And the 3D shows you the part of the bladder that's in the vagina. So let's look at these meshes. And you can see the mesh here. It's encircling the urethra, I think, to try and stop the urethra from moving back and becoming horizontal. But you can see it's fairly loose. It's not meant to be very, very tight. There's some that are meant to be tight, and I'll go over those with you in a minute. And if you look at the texture, now here we're a little bit tangential to the mesh here, and I'm just attempting to show what the texture of this mesh is that they put in there. So it's like a tape. In fact, it is a tape that has some width to it. So there are two tapes that are slings that are currently in use. You can see them both here. They're pretty obvious that you can tell which one you have when you're looking at it. This one goes straight across, and this is a obturator sling, and this is under some tension from the obturators on either side, and it goes straight across, and the urethra is up here, and that's under some tension. This one is called tension-free vaginal tape, TVT, and it is slung around this way without the tension that you see in the obturator sling. Now, I'm not a urologist or a urogynecologist, so I'm not going to go into much detail because I don't have the detail about how these exactly work mechanically. But that's how they look. And part of what we do with ultrasound is we can determine when they're not in the right place or fractured and when they're no longer working. So let's look at some examples. Here is one. There's a sling right here. This was a TVT, and you can see the urethra here, but one side has come loose. And so this side no longer is attached. It should have been attached over here, like this. But instead, it's got loose, and it's tied around the urethra. So this is obviously not going to work very well for this patient. This sling is too low. So if you look at the urethra and the vagina, and the bladder, the vagina is back here, the sling should be up in here to hold things together. Instead, it has slid down to within just a few millimeters of the introitus. So that's not going to help very much. So let's see what happens when she valsalvas in a minute. So this is the same patient. Now this is mid-valsalva. You can see already things are not going well here. The bladder is starting to fold over into the into the vagina. Sling is up here someplace, and we're really not doing well. So let's see what happens when she actually valsalvas all the way Sling is down here. Let's see what happens. Sling is here. She valsalvas, no good. The urethra becomes horizontal, and the bladder goes into the vagina. Now this one had a broken sling with a fragment in the vagina that came to attention because of the patient's husband, if you believe it. So these can become loose and can be felt in the vagina if they become loose, and this one was one of those types. It was also quite low, as you can see over here. So it's important when you look at this in 3D to have all of your views up, because this shows you what the floor of the pelvis looks like, but this shows you what level you're at, because you can see the sling is quite low here, that it's not up here where you might think it should be. And here's the broken sling. Okay, now other things can come down into the vagina other than the bladder. Let's see this lady. She was having trouble defecating. And now during her Valsalva, there's a knuckle of bowel, this is stool with air, that is sort of knuckling into the vagina. And this patient actually cannot defecate completely without actually putting her fingers in the vagina and straightening this out. And so this is a rectocele, as opposed to ureterocele. Actually, the bladder is coming down somewhat as well. So these are totally different kind of problems. And there is yet one more type of problem. You might ask, what else can come down? Well, there's the bladder, there's the urethra, there's the rectum. And I was asked to look at this patient because the gynecologist was not sure what was coming, knew that something was coming down, but couldn't tell what it was. So now we're going to run the tape. And what's coming down? It's a small bowel. This is an enterocele, which means that when she valsalvas, it's the small bowel that's actually coming out into the vagina and into a pouch there. So this is much more rare, but obviously the fix is very different than if it were a rectocele. Okay, now what else can happen in the anterior compartment where the urethra sits? As you can have a urethral diverticulum. I'm sure many of the gynecologists among you have treated patients with that. It's not uncommon. And so here's the urethra. The view is always the same. Patient standing on its head, on her head. There's the bladder. Urethra is right here. We've blown it up. And there's a outpouching right here. And if you look at it transverse in the other 90-degree direction, you'll see that a lot of times they look complex. They're sort of complex cysts with septations and various things. They can get infected, and they can have sort of purulent material there. They can be quite painful, and they can get infected on a regular basis. That's a urethral diverticulum. Now you know it's a urethral diverticulum because it's coming off the urethra, and that's what happens to the urethra. So let's look at it in real time. As we scan through the urethra, there's the urethra here. Now we're going transverse. You can see the diverticulum off to the side here in this particular case. Now, this is another patient. Now this one, the diverticulum is coming off the back. So here's the urethra, and there's the diverticulum. Here's the urethra, there's the diverticulum. A lot of times you can't see the connection. A lot of times you see the urethra and you see a little area and there's no connection. And it's not because the connection isn't there. Sometimes it's just obscured by debris or whatever else is there. But these patients have pain on urination, perineal pain. Now this is a 3D video which shows the diverticulum. Let's run this video here, and now we're going to move the dot into the urethra, and this is, I'm grateful to Dr. Grossman for giving me this video. You can see the urethra here. Now she's going to move the dot into the diverticulum. Here we are now in the diverticulum, and you can see the diverticulum in all three views. And that's how you use 3D to sort of get your bearings and get understand the relationship between all of the organs that you're looking at and all the structures that you're looking at. This is an example of how to examine a urethral diverticulum. Now here's another urethral diverticulum. This one was sent to me for a second opinion for perineal pain. Nobody knew what this was, and this was a cyst, a little cystic area that is anterior to the urethra. You can't see the urethra in this particular view. What you can see here is the bladder, which is collapsed, and you can see the front of the very anteverted uterus. Now here we don't see the connection with the urethra, but we still know it's a urethral diverticulum because that's what occurs there. And it's pretty limited differential diagnosis there. Here's one that's very small. This is yet a different one. As you can see, they're pretty common because we have amassed quite a few cases. And so here's the urethra right there. There's a diverticulum. You've got the vagina right here and the rectum. You can see the diverticulum can occur anteriorly, posteriorly, to the side, wherever there seems to be a break in the wall or some sort of weakness in the wall of the urethra. And here it is again, right there. Now, vaginal masses do occur, and we're asked sometimes to evaluate what the mass is, and this is one of the more common masses. This is clearly a cyst that is running alongside the vagina, and I think many of you have guessed already it's a Gartner's duct cyst. You can see the urethra here, the vagina here, and the rectum there. And there's the cyst on the side, in the side wall of the vagina. These are usually anechoic, and they're usually asymptomatic, and they're usually incidental findings. Gartner's duct cyst. Now here's another patient. Now this one was symptomatic. So there's a mass along the side of the rectum this time. You can see it right here. It's not a cystic mass. It's a sort of ugly mass, probably more solid or filled with debris. But instead of being near the vagina or near the urethra, it's actually near the rectum. So here I've taken my sweep right there. So this tells me that this is quite superficial. This is quite near the introitus, near really the anus, if you will. So here we are looking at it more closely, so you can get really up close to it right here, and you can turn on the color, which is what we did, and is not a drop of color in there. And so what could that be? Well, you've got a mass with no color that's next to the rectum. This is a Bartleton duct cyst is what it was. Now here's another mass, and that's in the region of the posterior vagina. Again, we're on the perineum here. Turned on the color, there's no color inside it at all. So this is completely devoid of color. It looks solid though, or maybe just has debris in it. It's a vaginal epidermal cyst. And you can see it's pretty close to the introitus here. And this was tender, and that's why she came in. Now this one is a really ugly looking thing. Lots of color. I was really worried about this. This was in the vagina. Lots of irregular blood vessels. Looks really malignant, and I was very concerned about it. I didn't know where it came from. It was at the top of the vagina. So let's look a little higher, and now we're going to look at the cervix. And here's the cervix. This is the external os here, and this thing is protruding out this way through the external os, and you can see that there are feeder vessels coming from way up high in the uterus. So I thought this was going to be a polyp and even a malignancy. It turned out on pathology, to my surprise, and I lost a bottle of wine over this, it was a prolapse fibroid that was benign. So you never know what's prolapsing, but things that prolapse from inside the uterus, obviously the differential is going to be different. Okay, now here's a big mass. This sort of looks, well, sort of solid. Again, doesn't have any color in it. Certainly not completely cystic. Let's just see closer to it as we look at the texture of it. You can see it's pretty big. It's 8, almost 9 centimeters. It's homogeneous. Looking at it from the floor of the pelvis, you can see the urethra here. The rectum is pushed over. The vagina is pretty much pushed over and not recognizable. So what is this thing? Well, let's look at it in real time. It's in the vagina. Here's the urethra. There's the bladder. There's the rectum. Let's see what happens when she valsalvas. So here she's valsalvaing. This whole thing is coming down, and is coming down through the vagina, sort of trying to come out of the vagina. Let's go back one more time and run that clip again. You can see as she pushes, the whole thing comes down en masse, and so this turned out to be a vaginal sebaceous cyst. All right, now here's another mass. Now this one's a little bit more heterogeneous. This one, here we are still in the introitus here. We're looking down the vagina. This thing is extending sort of into the gluteal region, if you will. And it looked pretty solid. Didn't know what it was. And as you always should do when you don't know what something is, turn on the color. Wow, this had a lot of color in it. It was irregular. It was worrisome. This looks like a malignancy, a soft tissue malignancy, and sure it was. It was a leiomyosarcoma. Now this was another one which was huge, and this was filling the vagina and went out into the buttock region as well. I couldn't even get it all on the screen because it was so big. And this was a myxoid spindle cell sarcoma. So sarcomas live down there. They're pretty ugly looking masses. Sorry, this is this was actually the same mass. You can see the relationship. This was a huge mass, but you can see part of it as it's pushing on the vagina. All right, now here is another patient, young patient, and she has this mass filling her vagina. That's why she came in. So here we are on the perineum. This is the rectum. This is part of the bladder. And this is the vagina that is completely filled with this solid mass with a lot of blood flow. This is absolutely malignant until proven otherwise. And this was a lymphoma. And we've seen now a number of lymphomas in the vagina and cervix. It is a place where lymphomas can occur. All right, now here's a nice round encapsulated looking thing, solid mass, having some shadows, right near the introitus, which is where we are. Now we're looking down the vagina right here, and this thing is in the wall of the vagina. Let's turn on some color. And there's the color, and it really doesn't look very aggressive. The color is mostly on the outside. If you saw this in the uterus, you would think it was a fibroid. And here it is in the wall of the vagina. There's the rectum, the vagina, and part of the urethra going into the bladder. And this is, in fact, a vaginal fibroma. Fibroids can occur in the vagina separate from the uterus. Okay, so this was a patient who came in with a lot of pain in her labia. And so here is the mass. Again, it's solid, although it doesn't have any color in it, really, that I could detect. It was pretty close to the introitus here, and it was very tender. And in 3D, you can see its location is to the side of the sort of vagina urethral region right here. And this turned out, I had no idea what it was. It went to surgery. This was endometrioma, endometrial implant in that location. Okay, this was a very ugly looking mass. This filled the vagina, lots of color, clearly malignant, but actually emanating from the cervix. Now, things that arise in the cervix can actually fill the vagina, so when you're looking at a vaginal mass, you have to consider that it could come from the cervix. This was a squamous cell carcinoma of the cervix. Now, I want to spend a little time on bladder masses because we do look at the bladder when we do pelvic floor exams just to see if there's anything there that I call this the forgotten organ because we often look through it, not at it or in it. This is a thickening of the bladder wall. That's right in front of the uterus right here. This is endometriosis of the bladder wall. This is typical. It's fusiform. It's not fungating. It's got a smooth outer wall. It's really in the wall of the bladder, not sort of in the mucosa of the bladder. Now, if you compare this to this, which is actually a transitional cell carcinoma, you'll see that this, in fact, is fungating. Or it's clearly mucosal. It's got an irregular surface. It's got a lot of color. Totally different kind of thing. So this is a bladder carcinoma or a transitional cell carcinoma. Now here, this was a really amazing case, and I'll tell you about it. This was somebody who had postmenopausal bleeding for 12 months. And she went to see her doctor a number of times. The doctor did 2 endometrial biopsies that were negative. And then sent her out. And finally sent her to me to look at the endometrium. So here I am starting to look at the urethra, and there's the vagina, and going down into the cervix down in here. What's this? This is a big mass. And if you turn on it, you can see that it's really quite large, and it's very vascular. This is in the bladder. So then I'd start talking to the patient, and I say, well, you know, when do you see the blood? She said, well, when I wipe. And this had been totally missed as a bladder lesion by the gynecologist, who had thought that postmenopausal bleeding was from the up higher. And was looking at an endometrial biopsy. So this is really a lesson here to get a really good history and consider all the things that are down there, not just the uterus. Here's another transitional cell. This is very advanced. This transitional cell is really filling the whole bladder, and it's very advanced here. This one is a 71-year-old patient with adenocarcinoma of the uterus, which is invading into the bladder. So this is, I guess, a metastasis, if you will, or I guess it's a direct invasion of this mass into the bladder, indenting it, as you can see. And then this shows you a 3D. You know, you don't need to do this, but I thought it was an interesting picture that shows you sort of the surface, what the bladder would look like if you did a cystoscopy, for example. You would see the surface of this mass that is protruding from the uterus right into the bladder. Okay, endometriosis of the bladder. These are 2 different cases. One case is on the left, one case is on the right. This is your typical case where you have this fusiform thickening of the bladder wall in a patient who has pain and particularly at certain times of the cycle. And this is quite predictably endometriosis of the bladder. This one is a little less typical. First of all, they don't usually have that much color. This one had a little more color than I would have liked. But you can see that it also is really involving the front wall of the uterus and the back wall of the bladder, if you will, where everything is stuck together. This was proven to be endometriosis. I was a little worried because it looked a little bit unusual, but that's in fact what it turned out to be. And another case of endometriosis showing this mass-like fusiform appearance. And if you look from the surface of the bladder, you'll see that it's fairly smooth, the way that it protrudes into the bladder lumen. Okay, now what happens when you have injuries to the anus and the rectovaginal septum? Well, here is a nice rectovaginal septum, urethra, vagina, rectum. This is the internal sphincter, which is echo-poor. The echogenic part here is the external sphincter. This is the mucosa. Very nice to have several layers here. Okay, this lady unfortunately did not. And if you look at the sphincters here, you can see that there is a big erosion or defect right here, right in back of the vagina, right here. And this is where you would expect it to happen in childbirth, for example, where you can get tears, and that's in fact where this patient got the tear. And in fact, she had a fistula that they couldn't identify even with MRI. And here we are trying to find it along the wall here. I'm looking up and down the wall of the vagina with the rectum, which is right there. And you can see here that we found pretty much where it was pointing, what level that was at, and we can certainly pinpoint it pretty well with 3D ultrasound just going up and down and looking for where the defect is. Here again is the defect right here into the vagina. Now this lady had Crohn's disease, and she had a fistula as well. That couldn't be found. And so here's the bladder, this is the urethra, this is the vagina, and this is the rectum back here. And if you look really carefully, there is a break in the wall back here between the rectum and the vagina. And if you go with 3D, and here I've emphasized it obviously, but there is a discontinuity in the wall of the rectovaginal septum in that location. Now, there's a lot of work being done by the famous Dr. Dietz from Australia, and he is really an expert on the avulsion of the levator ani after vaginal delivery, which is probably the most common injury that happens to the bladder, to the pelvic floor after a delivery. So you can see the normal sort of smiley face of the vagina here, and the attachments to the levator ani are here and here. You can see the pelvic inlet, and this is courtesy of Dr. Dietz. And if there's a side that is injured, you can see that there's no longer a smiley face here. One side is down, and this side is still intact. So this is the kind of injury that is looked for in those patients who have had trauma with childbirth. Okay, so here is a normal floor of the pelvis, okay? This is the urethra, that's the vagina, and that's the rectum. Something missing here. Think about it for a second. You see what's missing. The rectum is missing, the anus is missing. This is somebody who had the anus and rectum removed due to ulcerative colitis and is actually has a bag. But just to show you that you can be quite accurate as what you can and can't see back here because the rectum is actually absent. So we've been at it here 45 minutes, and so I want to leave some time for questions. I really feel that evaluating the pelvic floor is not that difficult. It's got to be a dynamic exam. It can't be done with static images. You have to be working with the patient, ask the patient to Valsalva, see what happens. You can do a little clip so that you can archive it. Many patients really suffer from these issues, these pelvic floor issues that are very embarrassing when they leak or they have these difficulties. And you can really help those patients who have these problems. The study must involve real time, and it must involve 3D, and it must involve patient participation, where you can talk to the patient, have her Valsalva, or squeeze or do different maneuvers to help you see what happens to the pelvic floor during these different maneuvers. And I think ultrasound is likely to become the modality of choice for the pelvic floor patients. I mean, it used to be MR because the ultrasound didn't have 3D and you couldn't look at the pelvic floor en face. But now that you can, I really think that it's the way to go. So I'm going to stop here and see if there are any questions for me. Thank you very much for listening. So let's see if we find any questions, and if not, here we go. So as you can see, I didn't really measure anything or use a lot of numbers, and I know that people can really get into those and get a lot of numbers and a lot of detail here, but that's just not what I do. And so let's see, have standard orientation guidelines been established for the transperineal translabial scanning? I don't know that the actual guidelines have been established for pelvic floor. I think that we have some guidelines for pelvic floor that are probably available, but I don't think anybody uses them. We certainly don't have accreditation for it right now, and it's certainly something that needs definitely needs work. Now here's another question. Could you describe what settings you use while looking at the pelvic floor 3D, 4D threshold? You use a specific size region of interest box looking at the pelvic floor. I just put the probe back there and just push the button. I mean, it's that easy. I don't use any particular setting. Just like you would if you're using 3D to look at the uterus. You just put it there and you take your sweep, and then your uterus comes up and you get your coronal view. For the pelvic floor, you put your probe on the perineum, line yourself up with the urethra, the vagina, and the rectum, and then push the button. And then you just change the gains after you have your picture to make it stand out more. So the cystocele Valsalva clip shows some debris in the bladder. Is that a common finding with incomplete voiding? No, I haven't seen that many patients because we're really sort of starting to do this. But I think it probably is because these patients tend to have urinary tract infections. And if they're not able to void all the way, some debris is just going to remain there and probably result in some urinary tract infections. So it says you feel that this should be a part of normal protocol. You know, I don't think that it should be part of a regular gynecologic exam. I think that this should be done if a patient has symptoms there. And now we're getting more, we sort of taught ourselves how to do this in my practice, and we're starting to get patients referred. And it's starting to really be helpful to those patients. But the patients are referred because they are symptomatic. This is not something that you're going to do for screening. Because if the patient's not symptomatic, then unless there's a mass there, you don't need to screen. So no, this should not be part of the regular. We have seen the patient empty the bladder for a transvaginal exam. As here images have fluid-filled bladders. Is it better to have a fluid-filled bladder for pelvic floor? Well, believe it or not, all these patients have emptied their bladders. There's a little bit in the bladder. A lot of times when a patient empties her bladder and you're about to do the vaginal probe, you can know that there's still a little bit in the bladder. And it's not a bad thing to have a little bit in the bladder just to outline it. But all these patients have theoretically voided. Now, sometimes, they void, they come back in the room, they get undressed, it takes a few minutes, you get the probe, you get it dressed up. By the time you get back in there, a little bit of fluid has come into the bladder, which is fine. So we do empty the bladder and then use a little bit of fluid that's in there. So somebody says, I most often do trans-abdominal pelvic floor exams looking through the bladder to see the pelvic floor muscle contraction. Have you seen the benefit from addressing muscle function transperineally? I think that's an area of great interest to look at the muscle contractions and function. I think a lot of people get physical therapy for pelvic floor dysfunction. I have not addressed this myself, but it's certainly an area that would be interesting to evaluate and look into further. This is a fairly new field. A lot of this is coming out of Australia, and it's really not something that's used very much in America. So we're really starting to evaluate what we can and can't do with it, and I'm sure that we can do a whole lot more with it than what I've shown you tonight. What codes do you suggest for billing? You know what? I'm not familiar with the codes for billing, but I can certainly, if I can ask Kathy to get the name of who this person is who asked that question, and we can email the code for that. I can look it up. I'm sure there's a code for it. I just don't happen to know what it is. How many of your images are from endovaginal probe and some using a 3D probe? How do you decide which to use? I use a transvaginal probe only. I don't use a 3D probe. One of the main reasons is I don't know how to disinfect it. The transvaginal probe has a sheath on it, a condom, and then you go through a disinfection process where you put it in Sidex or you do whatever is involved in your organization. I wouldn't know what to do with a 3D probe in order to provide proper disinfection. So I know some people use it. I don't know how they must have a method, which I'm not familiar with. But I find that using the transvaginal probe is fine, and it also gives you the option of going in a little ways if there's something that you find that's halfway up or whatever. It gives you a chance to do that. So let's see. Are there any more questions? I think I've answered all the ones that were sent over my way. So I think that we will end the presentation at this point. Thank you very much for your attention, and I wish you all a really good evening. Thank you.
Wonderful, and thank you very much, Dr. Ben Asraf, and our thanks to all of you who participated in tonight's webinar. Everyone, please remember to complete the post-test and the activity evaluation. We hope you enjoyed this evening's presentation, and please join us again for future webinars. Good night, everyone. Have a great evening.